The altered grandma reflex. Let's talk about the most common diagnosis in the emergency department. Grandma is acting slightly different, so it must be a UTI. We've all been there. A 90-year-old patient arrives with acute confusion. Before she's even out of the triage chair, someone has ordered a urine culture. And when that culture inevitably grows E. coli, as it has probably done since the late 90s, everyone stops looking for the real problem. We call it the scapegoat culture. The innocent bystander, ASB. Here is the scientific reality. Asymptomatic bacteriuria, or ASB, is essentially a normal finding in the elderly. In long-term care facilities, the prevalence of ASB in women can be as high as 50%. Finding bacteria in an 85-year-old's urine is about as clinically significant as finding gray hair on their head. It's there, but it's not the reason they're trying to eat the TV remote. The delirium trap. When we blame a UTI for delirium without localizing urinary symptoms like dysuria or suprapubic pain, we are doing our patients a disservice. By labeling it a UTI and hanging the ceftriaxone, we stop the diagnostic workup. We miss the real culprits: the new polypharmacy, the dehydration, the fecal impaction, the occult pneumonia, or the fact that she hasn't slept in 48 hours because her roommate keeps snoring. The smell test fallacy. And let's address the smell test. I know, we've all heard it, but doctor, the urine smells really strong. Colleagues, the literature is clear. Foul-smelling or cloudy urine is a sign of hydration status and diet, not an indication for antibiotics. Treating a smell is not evidence-based medicine, it's aromatherapy. The risk of treatment. Why does this matter? Because when we treat ASB in the elderly, we don't cure the confusion. Instead, we give them C. diff, we give them a drug rash, and we cultivate MDROs that will be much harder to treat when they actually do get sick. The IDSA guidelines are very clear. In the elderly, delirium without localized urinary symptoms is rarely a UTI. We need to resist the reflex to treat the paper just because the lab is positive. Next time grandma is confused, let's keep the specimen cup in the cupboard for a few minutes longer and look at the med list instead. Your patient and their gut microbiome will thank you. Let's practice diagnostic stewardship. Thanks for listening.